Welcome back. This is part two of our two-part series discussing the coronavirus. Our first part discussed the virus in a little bit of detail, its comparison to the influenza virus, how it does in certain temperatures, humidity, and exposure to UV light. Um, and some of the characteristics of the spike protein, how it binds to a human cell via the ACE2 receptor, comes into the cell, replicates, and how our body subsequently mounts an immune response to that. So this is I guess, the culmination. This is what I really wanted you guys to understand is the vaccine. I hope it kind of takes away some of the hesitancies, some of the worriment, some of the confusion associated with the vaccine, and help you make a well-informed decision regarding the vaccine itself. So this is a disclaimer. Basically, I'm providing you guys with some information regarding the COVID vaccine and also coronavirus itself. And ultimately, it's a discussion that you're going to have with your healthcare provider in the future. So once again, coming back, let's talk about SARS-CoV-2, which is also known as the novel coronavirus, also known as COVID-19. So we're going to focus on the spike protein in this particular video because that's effectively what's going to help us create the mRNA vaccine. There's a bunch of vaccines, but the ones that are coming out pretty soon are the mRNA vaccines. And we'll talk about that more in depth as we go through this video. But if you look here, this is the spike protein once again. This is an electron microscope image of the virus. In the center, you see a 3D model. The spike protein is in red. And then also over here, we have the S1, S2 subunits of the spike protein along with the membrane, the RNA that we talked about, and how necessary the RNA itself is to produce a spike protein, but also to help the virus replicate. Without the RNA, it's basically innocuous. It can't do anything. So let's push forward. And so looking at this model once again, basically on the left-hand side at the top, we basically have the spike protein. Remember, the receptor binding domain is what's important. Without the receptor binding domain is that small piece of the spike protein that essentially binds to the ACE2, which is the locking key. Remember, the lock is the ACE2. The key is the spike protein. Just think about the receptor binding domain as being the long portion of the key, not the head of the key, but the long portion. So the long portion is necessary to insert into the lock and turn it. The head of the key is basically just so you can put it around your keychain. And so basically we have these respiratory droplets that are carrying the SARS-CoV-2 virus, the coronavirus. It's circulating in the air. You inspire it. It gets into your lungs. It gets into the lung cell. The lung cell is displaying this lock here, and the lock is basically ACE2. That's the name of the receptor or the lock. And then the spike is basically what's necessary from the virus itself for it to bind to the ACE2 receptor. Once it binds to it, it basically comes into the cell, it starts replicating, it starts making copies, and then it's pushed out. And then remember, we talked about the antigen presenting cell here over here. Basically, this breaks down the virus and it presents pieces of the virus to other parts of the immune system, other cells such as the helper T cells. And those helper T cells are mediators to the B cell, which is the one that helps to create the antibodies, and the cytotoxic T cell, which basically kills off cells that are infected with a virus. All important stuff so that you understand where we're going. So what the mRNA vaccine itself is going to do is that it's going to create, mRNA is basically instructions to create a protein. Okay, so think about it like this. If I have instructions on how to build something, I'm going to use those instructions to build something. Okay, if I don't have the instructions, I probably can't build it. So, and basically the mRNA that's going to come from the mRNA vaccine will be used by our cells to produce the spike protein. and that's it, nothing else, just the spike protein. Okay, so basically, some of the traditional vaccines that you're used to, like the flu shot, emphasis on shot, the flu shot is an inactivated or killed version of the virus. So we're actually giving you the virus itself, but in an inactive state. There's other forms of, there's also a live attenuated, which is basically a weakened version of the virus, of a virus. And then there's actually when we give just the protein or a specific protein, so how in the mRNA vaccine we're talking about how mRNA creates the protein. Well, what if we just gave the protein? It's a very lengthy, expensive process, and it takes a long time to just make the protein. But the HPV vaccine holds that technology. So basically, we're going to hijack our cellular machinery to create spike proteins, and that's going to trigger an immune response, once it's presented, to the immune system. So basically, all we're going to do is, we're going to present the muscle cell with mRNA. It's going to go inside the muscle cell, and then inside the cell, it's going to use a printer. I heard that terminology and I thought that was great, but basically it's a ribosome, but we'll call it a printer. So the printer will make the protein, and then the protein will effectively present itself to the immune system, so that the body can mount a response to it, like creating antibodies or creating memory that will show us that in the future, if we see something similar to the spike protein, we can mount a defense to it. So it's going to be given on the upper arm and the deltoid. And some key things to understand. When we give the mRNA, it's not going to last long. So it actually can't even travel far. So that's why it's basically gonna stay here in the muscle cell. It's not gonna end up, somewhere else, because the likelihood of it being able to travel that distance is it's kind of difficult to imagine. mRNA is not something that's really, tough or anything. It's something that will not last too long. And if you want a number, so typical, like with some research that I did, like human mRNA, just that it tends to last, half, like if you have a baseline and then within, a couple hours, like say 10 hours, you have half of that. So it's not going to last more than a day probably. So be that as it may, somebody asked me, well, Cesar, is it when they give me this vaccine, am I going to have this instruction for the rest of my life? No, you're not going to have the mRNA that was given from the original vaccine in your body forever. It's only going to last a couple hours, if not, a couple minutes, and then it will disappear, and that's it. Um, and uh, and so that's an important thing for you guys to understand. But the important thing also is that all we have to do is show, this foreign, piece of a virus to our immune system, so that it could effectively mount a response over the course of time, hopefully for a long period of time, something that we don't know yet. But that's the case. And the next important thing for you guys to realize is that mRNA vaccines are not new. Now, granted, this is the first time we've ever done this, like where it's effectively going to be, passed. But these have been around for a while, and we've looked at them in studies, like looking at their use in influenza, Zika, rabies, cytomegalovirus, and in actuality, this is something that's been going on for almost 30 years, this technology. There was a gentleman, actually a group of scientists back in 1990. What they did was they injected some mice cells with just RNA and DNA with no protection whatsoever. All they did was inject that, and they were able to produce proteins that were in that, like the RNA and the DNA had instructions for. So the DNA and the RNA had instructions, and the cells were able to create that protein based on those instructions that were injected into the cell. But there's some challenges that come with this. You just can't inject, mRNA without any kind of vehicle or protection. You do that, your body's going to mount a crazy response. So we needed a vehicle. And so that's why it took a super long time, but it ended up happening in 2005, where they made some changes to the structure or the form of this technology, and they were able to increase protein production. So if we just had injected mRNA or RNA by itself, we probably would have ended up having just a little bit of protein production, and then it would have just degraded like super fast. That's kind of why, this whole temperature situation about how we're distributing it, how it has to be at a certain temperature, because it's so delicate. But if we would have just injected it, like, we would have had this crazy response. But now that they've made some changes to it, it was like kind of revolutionary in 2005. They the it doesn't The immune system doesn't mount a crazy response like it would before. And now, I guess the key thing is the vehicle. Now they're in these lipid nanoparticles, and these particles carry the mRNA to our muscle cells. That's like the key. So because of that, we were able to create this magnificent vaccine that's effective. And I'm going to show you that towards the coronavirus. And when you have significant resources, that's kind of where you can do a lot of things. So one of the big questions is the efficacy. Why is it so efficacious? I mean, 95%. Now, I mean, we have to channel in like mitigation tactics like that we're doing, like 6 feet separation, also masks. Obviously, when we do these other tests of vaccine efficacy, we don't tell the patients to wear masks. We don't tell them to be 6 feet apart from other people, all that stuff. So that has to be you know transferred into the data. But some people even say that even though we have that 95%, if we look at it in real time, it might end up being 80 something percent, but that's still good. So but the efficacy also may come from the fact that, remember I told you that if we were to inject RNA into the body, we can create this inflammatory response. Maybe we just, with this changes in the structure of it, maybe we're just to able to downplay the immune response to a point where it's like super efficacious, but not harmful to the body. So that could be. So, and remember we talked about the receptor binding domain, that long part of the key. So it's going to be necessary for you to determine the difference between that. So this is the spike protein. It's also called S, and for you to remember that this is the receptor binding domain binding to ACE2. But important for you to note that the receptor binding domain from SARS-CoV-2 was almost identical to SARS-CoV-1. So we've already been looking at this since 2003. So like we've already been looking at receptor binding domains for SARS-CoV. So I mean, that's kind of like we've been doing research. That's kind of the most important thing for you guys to understand. And what we're going to target is a specific type of spike protein. So it's actually the prefusion spike protein. So as you can see, the spike protein doesn't stay in the same conformation or the same type, like the same structure or the same form. It switches. And so this is the one before it binds to the ACE2. So that's what we're essentially creating. But so we're getting the vaccine, we're putting it in the cell, we create a spike protein. And it's just to realize, like, there's 37.2 trillion cells in the body. They're about 20 microns in size. If we were to lay them out flat across, we could circle the world 19 times. But if you look, okay, so we have the human body made up of all these cells. There's a bunch of cells, trillions of cells, right? Each cell has DNA. And so from that DNA, if we go down here to the bottom, that DNA produces mRNA. So mRNA is what's the instructions to send to the printer, so the printer, which is the ribosome, to make the protein. So we're basically, once again, we're going to tell the cell, we're going to give it the instructions, here's the mRNA, make the protein. Remember that the mRNA is not going to last long. Eventually it will be degraded, and then it will be broken down and gotten rid of, and that's it. It won't exist anymore. So it cannot, incorporate itself into our DNA. So it's a forward process. You can't go from protein to mRNA. You go from DNA to mRNA to protein. So at least you can't make a spike protein to an mRNA, like so. And this is some graphic representations of everything that I talked to you about. So this is an older picture. So kind of, this is from 2017 when they were working on the influenza mRNA vaccine. So they were basically talking about how we were going to give the vaccine, intramuscularly, and then basically in the muscle cell, it was going to create the whatever protein that they were talking about, and then it's going to be presented at the top, and then the cytotoxic T cells, which are the natural killer T cells, which are the ones that kill the cell, that they would be activated, but also the B cells. Remember, the ones that create the antibodies. Those would be the ones that would create the antibodies, and so those also would be activated. And so then there's other stuff that the helper T cells. This is another open interpretation. I won't get into it too deep, but there's some signs that we're having some T cell activation with the with this mRNA vaccine. So two mRNA vaccines up for grab: the Pfizer vaccine and the Moderna vaccine. Yeah, those are their special names. And important for you to know, these are the inclusion criteria. So you have people that are over the age of 18. They made sure that the females were not pregnant, and they also had to be abstinent at least, anywhere between 28 days to 3 months, at least 3 months from the second dose, and they couldn't be breastfeeding. So this is going to apply to, this is something that you're going to have to discuss, with your healthcare provider. But this population in the trial did not include women that were pregnant or breastfeeding. And also it did include HIV patients, but they had to be, they had to have a certain CD4 count, and they had to have an undetectable viral load. Uh, Also, going back to the exclusion criteria, you could not be acutely ill or febrile for the past 72 hours. You couldn't be breastfeeding or pregnant, like we talked about. You couldn't have had, coronavirus in the past. And so it's an interesting conversation that we could have as well. And thinking like, well, okay, so if I've had the virus, can I get the vaccine? And then immunosuppressive or an immunodeficient state. There wasn't anybody that had autoimmune disorders here. Um, Also, so they're like, as far like, so we also have to think about the patients that are taking immunosuppressive therapies. They weren't included. Um, so a lot of exclusion criteria. Uh, so but this I think is important. So this, we talk about all this education, we talk about all this data and stuff like that, but I wanted to put a face to, to the name. So these are the creators of the Pfizer vaccine, two humble individuals, from Germany. They're Turkish. They're from children from Turkish migrants. They, had promised each other that they would create something that would, treat cancer. Um, and then they got married, and they actually went to the lab the very next day after they got. I mean, that same day they were back in the lab. Right after they got married. They live in a humble apartment, right next to their office. They have a teenage daughter. They ride their bikes to work. They don't have a car. That, like, this is what I want to convey to you guys. This is the science community. These are the people, that I've been experiencing my entire life. The director of the NIH, Dr. Francis Collins. I remember riding a subway train with him back in 2006. He was carrying his guitar, or sitting next to a Nobel laureate in a cafeteria with regular chairs. Having a, you know, you know, a your professor who is like a world-renowned vaccine expert, creating a vaccine for Ebola. Seeing that particular person at an electronic music concert. They're like humble individuals that like myself that want to um, create something for others and help people. That we have this drive, this passion to want to help people, and that's what a scientist does. Like, like we wake up and we hunger for knowledge, but more importantly, we hunger to help others, and that's what a scientist is. And I want you guys to understand that. And I'm pretty sure you guys already do. Um, but this is the Pfizer vaccine, and so this is the final analysis. They looked at 170 cases of COVID-19 in the trial of 43,000 people. Of those 170 cases, 162 people had it in the placebo group, 8 cases in the vaccine group. So if you do the math, 90% effective after 1 week after their second dose. And then it was 94% effective in patients that were over the age of 65. Um, they had severe cases, 9 in the placebo group and only 1 in the vaccine group. Some of the adverse effects were fatigue, headache, and yeah. So this is expected to come out or be approved. They're gonna FDA and the VRBPAC is gonna look at it on December 10th. So that's probably when they're gonna approve it, given the data that we've looked at. Um, so this is just a press release. We don't have the official 100% everything data that will be published pretty soon, but this is what I'm giving you guys. Diverse population, and it's all around the world. 150 clinical sites in 6 countries. The mRNA vaccine from Moderna, also 30,000 participants, 196 cases in this trial, 185 in the placebo group, 11 in the vaccine group. There was one COVID-19 related death, and that happened in the placebo group. It was deemed to be 94% effective, and after 2 weeks, after 2 weeks after their second dose. 30, this was the kicker, 30 severe cases, hospitalizations secondary to COVID, stuff like that, in the placebo group and 0 in the vaccine group. They didn't tell us the side effects this time around in their final analysis, but when we were looking at their interim analysis, which only had 95 infections as opposed to 196, they had some fatigue, myalgia, arthralgias, headaches, pain. So when you get this vaccine, don't be surprised if you feel some pain or discomfort to the area. You might feel some fatigue, some headache. It's probably going to be pretty common. And the thing is, it's going to fade away after a day. The next day you'll be perfectly fine. It's just your body basically just think about it like this. It's in a relaxed state, and then all of a sudden you show it something that it's never seen before, and it just freaks out, and it just goes crazy, and it wants to attack it, but in a controlled sense. It's, I guess, controlled chaos. That's probably the best term for it. And their meeting is actually December 17th. So right after Pfizer's EUA meeting, they're going to have the Moderna meeting. And so pretty soon, before the end of the year, we might have our first batch of people that are vaccinated. That's impressive, considering where we were at. January 2020 was the first case of coronavirus, and before the whole year has gone, we already got a vaccine. That's impressive. So these are the vaccine comparisons, as far as like the other vaccine efficacies for the other ones. We do really well with tetanus and Ebola. Flu, we don't do so hot with. So you saw that we had 94 and 95 for these associated vaccines. And remember what I told you, though, we have to factor in mitigation protocols, and we also have to think about, well, maybe the response is a little bit more robust because it's mRNA. Now, this is the kicker. I know these are crazy, but I want you to understand this, because if you understand this, you can see that the vaccines work. It's important for you to understand that the vaccines work and they're efficacious, and it's not just, okay, everybody, the vaccine works. Well, I'm going to show you. And I know it's a little bit of a challenge to do that, but if I don't do that, I think I'm kind of like, holding you back, because I think this will show you. So for the most part, the antibodies that vaccinated individuals produce will effectively bind to the spike protein, and they'll bind to the receptor binding domain. How do I show you that? So the first 2 portions at the top will show the binding, and then the bottom part will show their neutralizing activity. So let me orient you. Just picture this. On the left-hand side is the amount of antibodies. On the bottom is the study day, and then you have them separated into groups from 25 to 100 to 250. These are the doses that were Moderna was experimenting with their phase 1 trial. So obviously we ended up with the 100, but before that we had the 25 and the 250. So so okay, so we're going to talk about antibody levels. Just focus on the first top two ones. So basically this is the spike protein, this is the receptor binding domain. So we're going to give the first shot. Remember, there's two shots. Okay, day 1 and then 28 days for the Moderna vaccine is shot 2. So we're going to give the first shot, right? So we give the first shot, we don't have any kind of antibodies. Then all of a sudden we give the shot, and 14 days or 15 days or 14 days after, we have effectively created antibodies that bind to the spike protein and bind to the receptor binding domain. So this is just the 25, this is the 100, and this is the 250. Now, the most important thing for you to orient yourself with is convalescent means these are individuals that were infected with coronavirus, in the regular population. So what happened was we gave the vaccine, we created antibodies, we gave the second dose right here after 29, and it's jumped up. It did better. So this square here is kind of like the median for the convalescent individuals. So we are effectively creating antibodies that are binding as good as people that have already gotten the coronavirus. Okay? If not, sometimes better, because we're doing a little bit better than the mean, right? Okay, now the bottom part is, so important for you to note that we've already created antibodies 2 weeks after the first dose. So even then, but why do we have to give 2 doses, Cesar? Why can't we just give 1? Well, if we give 1, the neutralizing ability is not there. So this is what we see here. So we gave the first dose and we didn't have any kind of neutralization. This is called the pseudovirus. This is like a fake virus. It's not the actual, coronavirus, but they make it to do stuff like the coronavirus. And then this is actually the coronavirus itself. It's a live wild type coronavirus, and it basically, it did still mount a defense to it 43 days after the first dose. So it already gotten their 2 doses and they're already still mounting antibodies, almost better, if not equal to the people that have already gotten the coronavirus. So does it work, Cesar? It's showing that it's binding to the spike protein and it's neutralizing to the spike protein. So does neutralizing actually prevent you? Because we're not actually giving these patients a challenge, basically exposing them to coronavirus. But we have done this in rhesus macaques, which are obviously an animal. And so these animals were basically vaccinated, they were created antibodies, and then they were challenged. And when they were challenged, they did not get pneumonia. But something else is still happening that I wanted to talk to you about. Okay, let's push forward. Let's go to the next thing. So does this last long? So yes, it does. So we're looking at data from 119 days, almost 4 months. And from 4 months, we're still, now, let me orient you again. This is the amount of activity, antibodies, things of that nature. These are the days at the bottom. So we give the first dose, we spike up, we make antibodies that are binding to the receptor binding domain, and then it drops a little bit. We give the second dose and it spikes it up again, and it leaves it all the way up to day 119. Now, this is the neutralization activity. So when we give the neutralization a look, we're seeing that, okay, we give the first dose, it drops a little bit. We give the second dose and it goes high, okay? Now, but it starts to drop a little bit. So that's our concern, that maybe in the future we might need to give a booster, but at 4 months for right now, it's still working, It's still doing its job. And then the other thing that came out of this paper was that we were able to note that 43 days after vaccination, we were enlisting the T cells, not just the B cells, but we're also using the T cells to fight off this infection. The important thing for us to realize also is that we're trying to look for sterilization or sterilizing immunity. So basically, it's a one and done type of thing. We're exposed to the virus, and then that's it. We don't want to ever have to deal with coronavirus again. That's kind of what we see with measles. When we vaccinate towards measles, you know, the patient never gets measles because our body is just, it has sterilizing immunity. The only thing that we've seen is like with the rhesus macaques, when they were giving the vaccine, the Oxford vaccine, that's not the same vaccine. That's a different vaccine, so we can't really apply 100% to this. But when we looked at the rhesus macaques, they basically neutralized or prevented themselves from getting pneumonia when they were challenged, but they were still able to find viruses inside their upper airways. So basically, what could happen is, and this is important for you guys to understand, even though you get vaccinated, you probably still have to wear a mask. And that's more for transmission's sake, not to prevent you from getting, clinical disease. But transmissibility is still up in the air. We don't really know. So you're going to be protected from the infection, but we don't know if you're going to you're going to be able to protect yourself from transmitting it to someone else who's not vaccinated. So this is the incidence. It's highest among young adults. Basically, that's new cases of the disease. It usually causes mortality in patients that are over the age of 80. As you add on disease states, particularly chronic kidney disease, diabetes, severe obesity, hypertension, that increases your risk for hospitalization. Important for you guys to understand. And then as you increase in age, you're more likely to die in the hospital. So if you're hospitalized as your age increases, you're more likely to die in the hospital from COVID-19. And the majority of the patients that were hospitalized for COVID-19 that were over the age of 75, those came from long-term care facilities. Important for you guys to understand that because they're part of the first phase that are going to get the vaccination. So as a matter of fact, phase 1A includes healthcare personnel and long-term care facility residents and staff, mostly because they made up 6% of the cases, but also 39% of the deaths in the US. So it's important or imperative that they get the vaccine. And then essential workers come after that. That includes, our, police force, firefighters, transportation, food service, educators, things of that nature. And then at the end, in 1C, basically that's when we have the patients with high-risk conditions, such as diabetes, hypertension, but also adults over the age of 65. And this is a potential time frame. So after 5 weeks, phase 1A should be phased out, and we'll start with phase 1B, and then we kind of go like that. So the purpose of this talk was to kind of inform you guys, because what was noted is these are surveys, right? So this survey was taken in April, and then this survey was taken in September. So, and these are the percentages given by ethnicity or race. And basically, for example, if we look at the Hispanic population, we started off at a 44%. In May, we increased to a 74%, and then now we're actually sitting at a 56%. The African American population, they started out at 39%, they went up to 57, and then all of a sudden they dwindled down to 32%. So if it's important for us to understand this, because herd immunity is key. So herd immunity means that people either need to get coronavirus or they need to be vaccinated by a vaccine for the coronavirus. So in order to obtain that, for us to kind of go to normal, I guess, so to speak, that's kind of open for interpretation. But in order for us to kind of go back to pre-COVID era, at least 70% of the population has to be vaccinated or had the disease. And so if we don't get that from the survey, it's kind of hard to say that we're going to go back, and a lot of people tell me, well, you know what, I'm going to wait. I'm going to wait till we have more information, or I'm going to wait till this person gets it. And so we've kind of have 4 months of data. If something, like, so far, the way I look at it, the data is like, as far as adverse events, we haven't had anything crazy happen. You know, they talk about a death in Brazil, but that patient did not get any type of vaccine. So uh, and most importantly, it's coming home. We have about 2,925 vaccines coming to us as early as the week of December 14th to Laredo, Texas, and that's for our hospital task force. So, in summary, I've given you the data. Is it efficacious? Yes. Is it harmful? Based on the data, the adverse effects are, minimal and they're temporary. And the question is, well, Cesar, are you going to get the vaccine? And I'm going to, resoundingly say yes. I will get the vaccine because these are my own personal convictions as to why. But I feel like it's my civic duty to get the vaccine to, help my patients, in the sense of preventing transmissibility to them. But also because I care about my family. I don't want to transmit this to other people. And more importantly, I don't know what the outcome will be if I do end up getting the disease state itself. So, a long story short, I feel like I should get the vaccine, and my wife is kind of on board with me as a healthcare provider as well. So she's going to get the vaccine as well, and I hope that hope you guys also will entertain the thought of getting the vaccine, and let's put an end to this coronavirus. Um, I love you guys. I know I don't know some of you guys, but as a person that cares deeply for humanity, I hope and pray that you're doing well, and that you would continue to do well in this pandemic and for the rest of your lives. May God bless you guys, and I hope this was helpful. Take care.